Welcome to Make America Healthy Again. Join Dr. Charles Antinori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antinori.
Hey, this is Dr. Charles Antinori. It's Make America Healthy Again. And today we have Dr. Chris Bashian, one of the guys I've known for a long time and helped train. And we're going to be talking about bariatric surgery. And if we have time, which I don't think we're going to have enough time to get to robotic surgery, but that might be another one another day.
Sure. Yeah,
Chris,
sure,
you want to just go over briefly your background for people?
Sure. Yeah. From South Jersey, born and raised, went to undergrad here, did my medical school here, did my residency here. Dr. Antinori helped train me in my residency. I went on to do a fellowship in Annapolis, Maryland in bariatric surgery and robotic surgery. Came back to South Jersey to practice where I am now, and I'm currently the director of the bariatric program at Inspira Medical Center in Mullica Hill, and also the chair for the division of robotic surgery.
Wow. Yeah. How many years have you been back, Chris, now? How many years have it been?
I actually just finished my 4th year in practice.
Wow. But things going fast. They went by fast.
Yeah, it really did. It's crazy.
So, like I said, why don't we start off about bariatrics, and we'll go from there. Yeah.
Sure. So, I guess just in general, for anybody who doesn't know, bariatric surgery is weight loss surgery. These are elective operations that we offer to people. We have a certain set of criteria for it. A lot of which has been sort of met with, the insurance companies and sort of what we determine to be appropriate. It goes by body mass index, which is calculated from your height and your weight. And anybody with a BMI of 40 and over is an automatic candidate through insurance, and they'll pay for your operation and all of the treatment plans leading up to it. If a BMI is between 35 and 39, we have to demonstrate that there are what we call obesity-related comorbidities present. And these are things like type 2 diabetes, obstructive sleep apnea, hypertension, lower extremity edema, PCOS. We have a long list of things. Acid reflux.
Almost all the people will have one or two of those, I would bet.
More than likely,
35, yes, yeah.
Yeah, once you achieve a BMI of 35, you're really starting to get into the danger zone with these with comorbidities. So
I guess for generic population out there, 30 is the beginning of overweight. They say you should be 23, but actually I've seen studies that say that people actually do best between 26 and 27. So the average person, there's a little debate about that.
For sure.
And they call anything 30 overweight. I'm right on that. That's touchy for me because I am right on that 30 brink.
Yeah, for sure. And BMI is not right. It's not the end all be all. It's kind of unreliable because it really doesn't take into account muscle mass. We actually do have now a scale in the office called a SICA, where you hold on to the handles and it actually starts to measure visceral fat and skeletal muscle, and that takes it into account when we're actually showing people what their body's comprised of. So it's helpful in developing a treatment plan for them that way too.
Right. And the other thing I guess we should mention real quick, Chris, that people have to, you mentioned it, but I'll bring it out. You can't just walk into your office and get this surgery. They have to be evaluated by medical people and psychiatrists too. Does it have to, or a psychologist or something?
It has to be a mental health provider. It can be a therapist. It can be a psychologist or a psychiatrist, as long as they're certified in counsel. That's part of it. And then a lot of it is a pretty extensive medical testing. We have to get clearance from a cardiologist and a pulmonologist. And more than likely, we leave it up to them to do any further testing on the heart and lungs, whether it be a sleep study, or echo, or even stress test. We do, everybody gets a preoperative upper endoscopy. So we go in with a camera while patients go to sleep for it. We look at the inside of the stomach. We're evaluating for things like problems with the esophagus, like esophagitis from severe acid reflux that can lead to Barrett's esophagus. We're looking for H. pylori. We always take random biopsies for a bacteria called H. pylori, which can contribute to other problems afterwards. We also get an X-ray test called an upper GI series, where you drink contrast that follows the flow through the upper GI tract, and an abdominal ultrasound. So we look at all of the solid and hollow organs inside the abdomen, including the gallbladder, looking for gallstones.
Again, let me just interject again for the lay population. These are serious operations. You know, that's why you have to do anything you do on somebody with a BMI over 35 is a serious operation. And all those conditions you mentioned, I always just say about bariatric surgery, the indications for bariatric surgery are basically the contraindications to virtually every other type of surgery. Diabetes, obesity, sleep apnea. These are the things you try to avoid if you can, in elective operations at least. And it's a very serious thing. I'll also interject that there has been a history with this. When I first started out, they were doing it with open midline incisions, and that's what's made. I think bariatric surgery got much more successful when laparoscopy came along, where it could be done, and now I guess you're going to say we're doing it robotically, but at least robotically and laparoscopically are sort of related, as we'll go into. But the fact that you don't have to make a big, long or even a medium-sized midline incision on these people with BMIs greater than 35. When we say, and again, for the lay people, BMI 35 usually means you're 250 pounds, somewhere in that ballpark, and
about
depending on your height,
depending on your height,
say 250, maybe even closer to 300 if you're taller.
Even less than that, believe it or not. We get some people who are on the shorter end, 5 foot, 5'1". If you're in that range, you're probably around 200 pounds, and you have
right. Females especially, I'm sure. Too.
Exactly.
So anyway, so what are you doing now? What are the operations now?
So the most common operation that we offer, and also it's the most common operation in America now, called the gastric sleeve, which has now been around for about 25 years, 30 years about. And basically what we do is we divide the stomach in half, essentially vertically. So what you're left with is sort of a skinny tube shaped like a banana. So that becomes your residual stomach. The whole point of the operation is to make the container smaller. So you're eating small bites of food. You're getting full very quickly. The other piece of stomach that gets divided away from that is removed from the body completely. And the point of that is actually where the hunger hormone is created, called ghrelin. So by getting rid of that piece of stomach, those ghrelin levels go down, and it leads to a reduction in your appetite after surgery. So the two ways that a gastric sleeve, comes into play here is it's a restrictive operation, so it's limiting food quantity, and you're also getting that appetite reduction. So you're attacking the weight loss in two ways. And the benefit of a sleeve is the least invasive operation that we have for weight loss. I would say the industry standard is about 5 small incisions on the abdomen to do a gastric sleeve. But to your point, with the advent of the robot, we're now able to get that down to 3 incisions, which is a less painful, quicker operation and safer operation for the patient. So almost everybody is in the hospital for one night. That's mandated, but almost everybody leaves the hospital in under 24 hours. So gone are the days of the big incisions, to your point, where people are in the hospital for 3, 5, 7 days. So it's all under 24-hour stay.
And wound complications used to be so common in people with these really thick abdominal walls. When you had to do a big long incision, there were so many wound complications from it. Just there, I really like. The sleeve is great. Like they've told you, I have a checkered past. Not that I did these operations, but just for taking care of people with these operations. And I told you the story about the girl that had the GI bypass when I was 3 months into my internship. That we were putting in a central line to hyperalimenta because they had GI bypass, means you bypass almost all the small intestine, and a lot of people went into liver failure, which is just what this 18-year-old 300-pound girl did. And now we're hyperalimenting, nourishing a girl because her liver's failed from our operation. That was one. The other thing, when I was on call, when I was at Cape Regional. I don't want to mention any names, but there was a local surgeon in the area that did a lot of gastric bypasses. And that was a successful operation. I'm sure you'll talk about it. It's more complicated than the sleeve. But when the people lose the weight, a lot of crazy things start to happen, and with bowel obstruction and things like that.
So there's that's true. And so with the gastric bypass, the techniques in gastric bypass have come a long way. And gastric bypass, as I'm sure, was developed as a weight loss operation after doing partial gastrectomies and antrectomies for perforated ulcers before the advent of PPIs. So what they noticed that after all of these, these Billroth operations and partial gastrectomies, these people started losing weight.
Right.
So,
I always used to tell people you're going to lose 30 pounds.
Yeah.
I did.
Yeah.
Tagamet, the first PPI, came out when I was like a third-year resident, and the volume of gastrectomies that the surgeons did, and by the time, you know, the guys, when I was an intern, the senior residents probably did 60, 70 gastrectomies a year. By the time I was a senior resident, it was probably down to about 30. Now it's probably down to like 5 or something.
Oh, yeah. Oh, it's unbelievably low. Yeah, it's unbelievably low.
But they make enough. They're doing gastric sleeves and gastric bypasses. So, you know, there's another operation.
That's when that's when you see it. Yeah. So, you know, it's been developed over, you know, almost, you know, 60 years, you know, with the gastric bypass, the Roux-en-Y, and now even the latest techniques today, we're seeing a strong decrease in those complications, like you're talking about bowel obstruction. One of the problems that can happen after a gastric bypass is the bowels can twist, essentially at one location where a new connection is made in the bowel. But with the new techniques and the new suturing techniques and the way we've crafted these, we've really reduced that rate to almost zero. We can obviously never hit zero itself. There's always a small risk, but it's a very small risk nowadays. The gastric bypass, I just, you know, just really quick, what I use that for, personally, if you put 10 bariatric surgeons in a room, you're going to get 10 different, you know, answers on who should have what operation. I would say it's probably, you know, 5 people will be about gastric sleeve and 5 people will be about bypass. For me personally, I reserve a more aggressive operation for specific patients with specific medical problems and higher BMIs. So it has to be medically necessary, in my opinion.
Right. I think that's kind of what I mean. Again, I read this literature just because I'm interested in it, you know. I also read about the bariatric medicine. We talked about that in another session I had just last week with a medical friend of mine. But you know, that seems to be the gist of a lot of people. They reserve it to get the bypass, the more complicated operation for the more complicated patients in a way. Tell us about the new operation you were telling me about.
Yeah, so it's called the SADI. It's an acronym, SADI, and it stands for the single anastomosis duodenal-ileal bypass. Long word, but the point of it, basically what they've done here is it's essentially a hybrid between the gastric sleeve and the bypass with elements of some of these older style bariatric operations that are no longer in existence. And basically, you know, as you know, trial and error will go throughout the years, we figure out what works and what doesn't. So you take the good elements and you combine it all into one procedure. So with the SADI, you do a gastric sleeve, and then you do also a rerouting of the intestine where you are making a new connection between the duodenum and the distal part of the small bowel called the ileum. So you're getting now a restrictive operation with the sleeve with that reduction in appetite because the piece of stomach is removed. And you're also getting a malabsorptive operation. So you're getting a reduction in the calories absorbed by the GI tract. So both of those together, you're now going to get even more weight loss. And actually, you're starting to see a reduction in things like acid reflux and all of these things right out of the gate because of the way that this operation is crafted. It's very safe. Again, it's an aggressive weight loss operation, and I really recommend this for people who have bigger BMIs, who have a multitude of medical issues, including type 2 diabetes. And as the literature is showing us, we're seeing improvement and almost complete resolution in type 2 diabetes with these operations.
You said you leave 300 centimeters of ileum?
It's 300 centimeters counted back.
But that's what? That's like that's a long. That's how many inches? That's like 100, more than 100 inches. So you're leaving a lot.
Yeah,
you're leaving a lot of bowel. Yeah,
you're leaving a lot of bowel. Yeah,
yeah. Like I told you, that operation didn't work. They didn't leave hardly any bowel.
Exactly right. So this was adopted from the historical operation, the duodenal switch. Which we still have duodenal switch, a standard duodenal switch. What we've modified is that number, that 300, because like you said, back in the day, they were coming right up to the colon. You're bypassing almost the entire
small bowel. Yeah.
So over the years, we've basically learned that 300 centimeters is the sweet spot where you have excellent weight loss and you have no problems with malnutrition in terms of, you know, vitamins levels dropping or anything like that. So we're not.
Let me interject something too. One thing that really is clear from the reading, and again, I've been sort of a skeptical guy about these operations, but there's no question. I mean, now they've been around 30, 40 years, and they do accomplish what they intend. The people lose weight.
Yes.
Diabetes goes away. The high blood pressure goes away. I mean, everything, all the parameters, they live longer, all the parameters that you're doing the operation, they really both do work, and they do have complications, but as you said, got that down to a pretty low level now.
Yep. We've actually, and I think we were talking earlier, they've done studies on this, comparing gastric sleeve and gastric bypass with appendectomy and cholecystectomy, which is gallbladder removal. Some of the most common general surgery operations we do almost every day. And the complication profile of the bariatric operations is actually less than that of appendectomy and gallbladder removal, which is significant. I mean, the field has come so far, especially in the last probably 10 years. Which in our field is actually a long time.
Are you doing them mostly robotically now, or are you doing them laparoscopically?
They are, for my practice, it's 100% robotic.
100%, okay.
I mean, so with the advent of the robot, it's fewer incisions, it's less operative time. You're getting a better operation because the technology of the instruments is better. And as a result, we are a non-narcotic program. So we don't use anything like oxycodone or Percocet, Vicodin, any of that. Pain control is managed with a medicine called pregabalin or Lyrica, which the patients actually start the day before surgery. They take it the morning of, and then they're on it for 2 days after the surgery. Aside from that, it's ibuprofen and Tylenol.
Wow.
So it's really led to really quicker recovery. We're not seeing any post-op constipation or any issues that come along with the side effects of narcotics. So it's been really good.
Yeah, that is amazing.
So we've got a lot of options, and really, the decision on what operation we go with is really a conversation between myself, the patient. We talk about their medical history and sort of what their goals are and what we're trying to accomplish, and sort of we land on a procedure that way. Program takes about 3 months to get through before patients can have the surgery. To get through all of the checklists. And again, it's all designed for patient safety to get people to the operating room in an optimized state. And we see really good results.
Yeah, that's great. I think we've talked a little bit about, have you been using the bariatric meds, the semaglutides and things at all? I think we talked about maybe using them on the really big people to try to get them down a little bit. Is that?
So there, obviously these are big nowadays. And in our office, we actually have the practice split. So I personally handle all of the surgical weight loss. We have another physician and a nurse practitioner who handle all of the medical weight loss and prescribing Ozempic and Mounjaro and Wegovy and these things. We have so many patients on that medical side, we had to divide and conquer, so to speak. But where we do really see some excellent success is when patients are put on the medication preoperatively while they're going through the program, stop it before the surgery, and then let the operation take over afterwards.
So they're getting that jump bit of weight. They lose a little bit of weight the months it takes to get evaluated. That's interesting.
They do. They lose a little bit of weight, and it also starts training them to eat a little bit differently. So that way, once you have the operation, it's not it's not a shock to the system. And again, the medications come with their own set of problems. Either insurance doesn't approve, or they cut them short right in the middle, or patients can't tolerate the side effects because you have to increase the dose as time goes on. So,
you have to increase the dose. You do, I'm trying to read about them. I mentioned them in the book in Make America Healthy Again, which I wrote, I guess, is like a year and a half ago now, and they were pretty new then. I mean, they were already established, but in the last year and a half, like you said, it's like a snowball rolling downhill. I mean, there's so many people taking them, but I'm waiting to see. I mean, I'm not hearing any horrendous complications, but there's no question there are complications, and they still are very expensive. I mean, it's still talking like what, $500 a month or $1,000 a month, something like that.
And it's really
gain the weight back when you stop them.
Right. Exactly. So it's a temporary. I think that, in my opinion, they have their place. I think they're good for patients who are not really surgical candidates. If your BMI is under 35 and you're not going to be approved for a weight loss operation.
Right.
You don't have other
That might be the
issues.
niche.
Yeah.
Speaking of a guy like me, that's like sort of 29, 30.
Yeah.
I don't, and aside even from the money, I don't want to take a pill to just try to get my BMI down to, 25.
Right. And that's the thing. There is
I don't know
no
what's wrong with this pill, but it's just like, that's not a pill. Well, actually, it is going to be a pill. I just saw an article on that the semaglutide is coming out as a pill, but up until now, it's been a weekly injection. It's still probably mostly a weekly injection, but yeah.
Right. We do have some agents that are oral, like phentermine, which is like really an appetite suppressant.
Yeah.
But, so they're on the more mild side.
Yeah.
But all of those, the ones like the Ozempics and things like that, those are all injectable. And,
Chris,
yeah.
And then we went more or less our 20, 25 minutes here. It was great. I thought we touched on robotic, but if you want, we'll have you back and do a thing on robotic.
I'd love to talk about robotics. Yeah, for sure. I appreciate it. Thanks for having me.
It's my pleasure. Thanks for talking. It's great.
All right.
We'll close this up. This is Make America Healthy Again, and we'll be back. I don't know, next week we'll talk about some robots, and I have a resident. When we get off, I want to call you on the phone, ask you some questions, but have a resident that knows all about the equitable private equity taking over a hospital around here. Yeah, I'm sure.
Really?
We'll talk about it on the phone. We might have another session on that.
Oh yeah, that sounds juicy.
Yeah, it's juicy.
Yeah.
Thanks again. See you.
Thank you.
Bye-bye.